especially a very close friend of mine, Ahmed Hegazi, that we spent some time in Germany in Atos Clinic during our fellowship, and he's behind this invitation as well. So I'm going to focus on the cartilage defects of the knee, not about arthritis, but focal defects. And I will try to show you some basic science data that we presented from our work in the Orthopedic Center in Athens. So, as you all know, articular cartilage injury is a permanent one, poor vascularity, no healing potential. It may end up to arthritis. You all know this study from Dr. Carroll from Duke University talking about the prevalence of cartilage defects in the knee. You're aware of the symptoms: pain, catching, locking, knee effusion. What are the goals of cartilage repair? We try to restore a smooth articular cartilage surface and relieve patient symptoms. What is the holy grail of this procedure? Trying to achieve normal high-align cartilage. These are the treatment options for the cartilage biosurgeon. You have many techniques you may use, but none of them is able to achieve high-align cartilage up to now. You all know microfractures, a good technique, arthroscopic one. What is the limitation? It creates fibrocartilage. So after a few years, the repair tissue is deteriorated. What about OATS or mosaicplasty? A very good technique. Limitation, donor site morbidity, and sometimes difficult to achieve joint congruity. ACI, the autologous chondrocyte implantation. Still, this technique can achieve high-align-like cartilage, but still it's open, expensive, a two-stage procedure. Other techniques, MACI or AMIC, you all know this. So, in our effort to obtain a high-align cartilage, what technique will yield the optimal result? We need to have an effective and available cell source to do that, combined with an effective scaffold. You may also use proper growth factors. We also try to do it as minimally invasive as it can be done. It should be cost-effective as well and have a high success rate and low complication rate. So, which technique can achieve this? This is where regenerative medicine or tissue engineering comes into play, because it can combine the use of stem cells with a scaffold and biological factors in whatever joint you may choose to do it. These are the basic principles of tissue engineering. You have different options of scaffolds, like Hytosan or hyaluronan or collagen type 1 or 3 bilayers, many options. What about stem cells? Most of them are adult mesenchymal stem cells. They have a source from bone marrow, peripheral blood, dental pulp, adipose tissue, muscle, and synovial membrane. You should keep that in mind. What type of stem cells? These are some specialized cells that can give rise to differentiated ones. They should be plastic adherent under standard culture conditions. This is one of their characteristics. Another one which should be obtained should be the tripotential differentiation capability into osteoblasts, chondrocytes, and adipocytes. And again, they should express certain surface antigens in order to be characterized as stem cells. What is the optimal stem cell source for articular cartilage tissue engineering? Some people use bone marrow, some people use adipose tissue derived. We try to use synovial membrane-derived stem cells. So what about bone marrow-derived? They are very easily obtained. You can use this YAMCD needle, and you can aspirate from the superior iliac spine. What is the disadvantage of it? You obtain a low tissue volume and a low cell volume as well. And aspiration is a very painful procedure as well. What about adipose tissue-derived stem cells that we already heard from so many speakers? It's very easy to obtain with this lipoaspiration, and you can obtain large amounts of them. You can have this stromal vascular fraction, which is a combination of adipose tissue-derived stem cells in a percentage of 30 to 40%, plus vascular endothelial cells, vascular smooth muscle cells, and pericytes. If you compare bone marrow stem cells and adipose tissue-derived stem cells, human adipose tissue-derived stem cells, they are shown to have a higher proliferative capacity. They also retain a differentiation potential for a longer period in cultures compared to human bone marrow stem cells. However, the adipose tissue-derived stem cells, they show a decreased chondrogenic differentiation capacity compared with bone marrow in vitro. However, if you choose to use certain growth factors like TGF or BMP6, this can enhance the chondrogenic potential of adipose tissue-derived stem cells to a level that is comparable to the bone marrow ones. So you can go for it. What about if you compare bone marrow versus adipose tissue-derived versus synovial membrane-derived stem cells? There is a nice study from Japan, Professor Sakaguchi. He obtained from human beings 8 samples during the knee surgery for ligament injury, and he tried to characterize the properties of mesenchymal stem cells isolated from bone marrow, synovium, adipose tissue, and periosteum and skeletal muscle as well. So he showed that in chondrogenesis studies, the cells were pelleted and cultured from a synovium membrane were shown to have larger size and to be more extensively stained for cartilage matrix. So it seems to be that synovial membrane-derived stem cells have a better chondrogenic potential. Our team from Greece, from Orthopedic Research Center of First Department of Orthopedics in Attikon University Hospital, we have published this study in Injury recently. So we took samples from New Zealand white rabbits. We've drawn bone marrow with an aspiration needle, and we also took from the New Zealand white rabbit knee, adipose tissue, synovium, patellar tendon, and medial collateral ligament. We did a comparison of all these stem cell sources, and we have seen that in terms of chondrogenesis, synovial stem cells express twice the amount of aggregan that cells from other sources have done. That's this one. Yeah, you see that? And also, when we try to do the pellets, you can see that the synovial membrane-derived ones, they created a larger pellet compared to the bone marrow. So you can conclude that in terms of tissue engineering, if you try to obtain the best chondrogenic potential capacity source of cells, you can go for synovial membrane if you wish to. These are all basic science evidence. So what about the clinical evidence that can lead to our clinical decision? If you try to look for studies in PubMed concerning the use of stem cells in focal cartilage defects, you will not find so many. So there is a study from 2010 where they used autologous bone marrow mesenchymal stem cells. They were culture expanded, they were placed in a fibrin glue, and then they were transplanted into the full thickness cartilage defects of the femoral condyle in 5 patients. The evaluation was at 6 and 12 months, both with clinical scores and X-rays and MRIs. And you can see that in a year, all patient symptoms were improved, all clinical scores were improved, and again, for those who underwent the second look arthroscopy, the arthroscopic scores were very good ones. And also the MRI revealed that there was a complete defect fill. Another study, this is a cohort, a level 3 study. It was a comparative one, so they compared ACI versus the use of bone marrow stem cells. Again, they used clinical scores, they used this quality of life score as well, and they saw that there was no difference between the ACI procedure and the bone marrow stem cell procedure. Another study about adipose tissue-derived stem cells. A small series, 18 patients. I mean, follow-up was 2 years. The adipose tissue was harvested from a knee fat pad. Again, clinical scores. They showed that there was improvement in clinical and MRI results. What about the synovial membrane-derived stem cells? A clinical study, again from Japan. A recent one from 2015, a small case series with 10 patients, again, focal defects of the knee. They did a synovium biopsy arthroscopically from the suprapatellar pouch. The stem cells were expanded for 2 weeks, and they were placed on the cartilage defect with their syringe under arthroscopic control, and they also underwent second look arthroscopy. What about the results? The impressive one is the histologic analysis, which showed that in 3 patients there was high-lying cartilage, which is what we pursue. This is what we want. What are the future perspectives of articular cartilage tissue engineering? It has already been told by the previous speaker, a very impressive talk. I liked it a lot. So it's 3D pion printing technology, okay? This is already to be done in many places around the world. I was at Wake Forest University in the US, where we also had this 3D printer with Dr. Atala, and you can use a combination of stem cells, whichever you want. Professor Abdelhamid showed the use of adipose tissue-derived stem cells. We think to use synovial membrane-derived ones. So you can use a hydrogel to print it on, and you can choose the technique that you can apply it on a focal defect in the knee. Whether you can do it arthroscopically or open, it's the same. This is another technique that comes from Australia. This is called the BioPen. They again use adipose tissue-derived stem cells, a handheld BioPen. It's very easy to use. You can print cartilage tissue on a focal defect, and they can use a hydrogel material to achieve that with a combination of adipose tissue-derived stem cells. So, if you try to have a take-home message out of this talk, it would be that the use of stem cells is increasing in animal and clinical studies. At least from our point of view, the greatest chondrogenic potential is obtained by synovium-derived stem cells. There are many different methods to deliver the stem cells into the joint, whether you can do it arthroscopically or with an injection or open. But however, you can say that still the evidence for a direct clinical benefit is still limited, okay? So further research is necessary to show the overall outcome of stem cell therapies for cartilage repair. So thank you for your attention.